Great. So thanks to Glenn and Jesse for putting us on the program. Delighted to see so many familiar faces. Good to be back in Chicago. So this is joint with Marika Cabral and Mike Geruso, both at UT Austin. And the really broad motivation for this paper is there's almost a perennial debate in the US about whether it's desirable to provide public health benefits through private insurance markets. So we saw this debate around the public option in the ACA. We saw it more recently around the Ryan plan for privatizing Medicare. I'm sure we'll see it again in various forms. So the arguments for private markets are competition reduces costs, improves the quality of care for beneficiaries. The arguments against is that privatization is basically a handout to the insurance industry. It's going to lead to large profits for those insurance providers, perhaps the erosion of benefits. From an economist's perspective, I think a lot of what people are talking about is incidence. Who reaps the gains from greater privatization, patients or producers. And when I think about incidence, I think about pass-through. And so what we're going to be doing in this paper is thinking about who benefits from sort of a marginal increase in the subsidies paid to Medicare plans. So a little bit of background, since this is not exclusively a care environment audience. So most elderly people in the United States have two choices of health insurance. One is traditional fee-for-service Medicare. That's about 70% of the market today. You can go and see pretty much any doctor. Pretty significant patient cost sharing, so deductibles, co-insurance, co-pays. The other choice that most people have is Medicare Advantage. It's about 30% of the market today. This is private coverage. It was traditionally offered by HMOs, restricted network of providers, little or no patient cost sharing, often supplemental benefits, vision, dental, drug coverage during our time period. So the way this product works is Medicare eligibles can choose any plan available in their county. It's guaranteed issue, so anybody can purchase it, community rated, so everybody pays the same price. These plans are given a capitation payment. That's basically a voucher from Medicare for each person who signs up. And plans can charge a supplemental premium. So the revenue to plans is just the capitation payments from the government plus the premiums that they charge beneficiaries. And so in the paper, what we're going to do is the following. We're going to ask to what degree is an increase in capitation payments, I'm going to argue to you is plausibly exogenous. To what extent is that passed through to consumers in lower premiums and more generous benefits? And then we're going to really try and decompose what are the economic factors which explain our pass-through estimates. And that's going to teach us, I think, about the factors which are important for determining who gets the rents in this market. More broadly, will be indicative of perhaps the types of policies we want to pursue if we want to make the markets function better. So that's where I'm heading. Let me give you a little bit more background so you understand where my variation comes from, why I'm looking at the outcome variables I'm looking at. Historically, in the 80s and the 90s, these capitation payments were set to basically an estimate of someone's counterfactual costs if they stayed in the traditional Medicare system. At some point, rather than using these average costs, which bumped around year to year, they just froze them and inflated them by 2% per year. During our data, they're also risk adjusting them a very little bit for age. For some basic demographics, I think the risk adjustment is like 1% of the costs. So that's how these capitation payments work. And like I said, we're going to be exploiting basically variation in these Bs, which vary by county and by time period. So what's the data we're using? We're using a number of different data sets. We have administrative data on all the payments to all the plans. In every county and every year. We see the government runs a website where people can shop for plans, where they see premiums, where they see cost sharing, where they see other plan characteristics. We basically have the information from that website. We have administrative data on the costs for all 70% of Medicare beneficiaries, so approximately 30 million people a year who stay in the traditional Medicare system. For people who choose a Medicare Advantage plan, their cost data is proprietary, so what we know about them is their demographics. Most of our data is going to cover this entire period, which is going to span our source of variation. Some of it only starts in 1999 because that's when they built the website. I think all the analysis I'm going to show you is at the level of the county year. That's where our variation lives, and so that's going to be the most useful way to do the analysis. All right. So our research designed to first estimate this pass-through parameter before we try and decompose it is going to take advantage of a sharp increase in payments that was determined by a piece of legislation known as the Beneficiary Improvement and Protection Act, passed in year 2000, implemented in 2001. The architect of this bill, Ken Conrad, was a rural senator from North Dakota, wanted to increase MA penetration in his state and other rural states. The issue was that, well, fee-for-service costs were very low there, so the payments to MA plans were quite low. So his legislative strategy was to come up with a payment floor. The payments could be less than a certain amount. That would bump up places differentially where his constituents lived. So, because of legislative politics, they ended up coming up with an urban and a rural payment floor. Our effects take effect immediately, basically after this legislation was passed. CMS reached out to the different insurers and said, update your prices, update your product offerings. So we see a pretty sharp immediate effect. Okay, so here's the variation in the data coming from these capitation payments. On the x-axis is monthly payments in year 2000 before the law came into effect. The y-axis monthly payments in 2001. And you'll see if you were below the urban or the rural floor, payments popped up depending upon your urban or rural status. So here's a map showing where the variation is coming from. The darker counties have higher capitation payments. Basically what this law did was truncate payments at the median. So everybody below the median popped up by differential amounts. Okay, so how are we going to use this variation to learn about the economic environment? Well, we're going to create an instrument which isolates the increase in capitation payments solely due to the law. We're going to call that distance to the floor. That variable is roughly defined as, well, if you're below the floor, it's the difference between what your payments were in the pre-period and the floor. That's the amount they're going to pop up. If you're above the floor, it's equal to 0. And we're going to actually create this variable for every year because we're going to want to look at the coefficient on the instrument in the pre-period and after the law was passed. So we're going to inflation adjust the floor into the pre-period and the counterfactual payments into the post-period using the statutory formula. Okay, so given this instrument, then we can just plug ahead with a basic difference in difference model. We'll have an instrument. We'll estimate the coefficient on the instrument in each year. Normalize the coefficient on year 2000 to 0 so we can look at effects relative to that point in time and cluster standard errors at the county level. Right. So the identifying assumption, I think, is fairly obvious in this setting. It's that in the absence of this increase in payments, outcomes for counties that were differentially treated by this legislative change would have evolved in parallel. Two broad approaches to assessing the validity of this assumption. I'm going to show you these beta coefficients over time. I'm going to show you that they're completely flat in the pre-period, which is going to be strong evidence of that parallel trends assumption before the law came into effect. I'm going to also show you specifications which isolate two forms of variation within the data. You might be concerned, for example, that places with different costs prior to BIPA are on different growth paths. The way we're going to address this is we're just going to control for a flexible polynomial in the pre-period growth interacted with year fixed effects. That's going to allow for different growth in different parts of the cost distribution, and will be identified by different size increases in payments due to the fact that two counties with the same pre-BIPA capitation payments saw different increases depending on whether they were urban or rural. That's one subset of the variation in the data. The other subset of the variation in the data is to control flexibly for urban or rural status over time, use variation in different size increases depending upon how far you were away from the urban or rural floor. I'm going to show that our results are highly stable to using these subsets of the identifying variation. Okay, so here's just the first stage. This is the effect of our distance to the floor variable on actual payments to plans. There's some other things going on in the world, some demonstration programs, etc. But it seems like our instrument is capturing nearly every aspect of the change in payments. Right? The coefficient on the instrument is exactly 1. These points have standard error bars. It's highly precisely estimated, basically because our first stage is 1 and very precisely estimated. I'm just going to show you reduced forms for the rest of the talk. Those are going to be basically the same as the IVs. Okay, so let me then just show you start by showing you the baseline pass-through estimates. Here's, I think, the first main result in the paper. This is the effect of a $1 increase in payments to plans on premiums paid by consumers, and you see they drop by about 35 cents, so pass-through of 0.35 in the first year and stabilize at 45 cents in years 2 and 3. In year 4, the Medicare Modernization Act comes into effect and basically changes the landscape. So we only have three years of post-data to look at outcomes. Here's effects on just sort of different statistics of the distribution of premiums in each county. I think the average county has 3 plans, so it's summarized by premium for the lowest plan, highest plan, and the median plan. You can see the whole distribution shifts about by 45 cents. It seems like this is leading to a across-the-board reduction in premiums. A whole bunch of robustness analysis in the paper, the subsets of variations, plans cancel negative premiums. We estimate Tobit specifications. This 0 lower bound isn't binding for the firms in our sample. Some plans set premiums at a more aggregate level than the county. If you use county level variation, you might be underestimating pass-through. We can run our estimates aggregating the data to the MSA by state level. Results are the same. So we think this result is pretty robust. Okay, what about benefits? So in the simplest model, see an increase in payments to plans. You should see basically most of that pass through on premiums. You would only see an effect on benefits if there was an income effect, right? So if consumers have, let's say, CARA preferences over risk, you wouldn't see any effect in the generosity of benefits. Of course, we don't think the real world is as simple as that simple model. So we want to look at effects on benefits. At least my prior was it's going to be small. Right? So we have rich data on all the other components of these plans. We can look at effects on each component individually. That's a lot of figures, a lot of tables. What we want to do is bundle these all together. So what we do is we monetize them by taking an actuarial value. So if there's a $5 decrease in copayments, we know from other data people go to the doctor 4 times a year. So that's going to be a $20 decrease in the actuarial value of the plan. We can do this for the different components. And here's the graph. We see a marginally significant 8 cents increase in the generosity of the plan. This is driven by pretty actually large increases in the large reductions in copayments, and basically everything else is flat. Finally, I think an issue in all pass-through papers is pass-through onto unobserved components of quality. My own view is we're pretty strong here. We see basically everything consumers see at the point of sale, so that's pretty useful for us. A lot of other characteristics are strongly regulated. Minimum essential benefits. There are no narrow network MA plans because there's strong network adequacy laws. We have a whole section of the paper where we have data on the quality of these plans from subjective evaluations of plan participants. Medicare surveys about 200,000 people a year. We estimate precise zeros here, precise zero on clinical outcome measures. Finally, plan availability, examine two margins, an extensive and intensive margin. I think that the bottom line here is we don't see anything going on, maybe marginally significant effects in year 3, but again, they're economically small and only marginally economically significant. I think I was originally puzzled by this, but what made me less puzzled is if you look at the data on the counties with no plans, they're really small counties with like maybe a couple thousand elderly people, and so the economics of slightly higher payments if you enter one of these counties, well, if you get 10% of a couple thousand people, you're going to enroll a couple hundred people. If you enter one of these counties, higher payments for a couple hundred people, only shifting the profits, the revenue from entering those counties by $50,000, $20,000. That's really a drop in the water for major health insurance plans when they're making their entry decisions. Actually not. Once I looked at the numbers, I wasn't surprised there was an extensive margin effect. Okay, so it's just summarizing then the estimates, dollar increase in subsidies, about 53 cents passed through to consumers. Okay, so then the second half of the paper asks, what are the economic forces which can explain this pass-through? And more generally, what I find useful about this part of the paper is it teaches us about what are the barriers to generating consumer surplus in health insurance markets. So what we're going to do is we're going to write down a simple model which is going to allow us to quantitatively investigate two mechanisms which I think are potentially the most important. Selection into the market, so this is going to be the upward sloping marginal cost curves that Tim was talking about 15 minutes ago, and the other factor is market power. So I guess this is the two factors. That's why paper and mine are bundled together. We're going to be looking at these same two factors. I'll show you very simply how these work graphically, but that's probably unnecessary in this audience. Then I'll present a model which is going to have the exact same notation as Dave's model. So I guess that's another advantage, that I have mu's and rhos and thetas, which mean the exact same thing. Okay, so here's the simple model. No selection, perfect competition, and an increase in subsidies to plans is just like a decrease in their marginal costs, and so it should be passed through one for one. The blue line is demand. These black lines are constant marginal costs. Suppose that people are concerned in Medicare Advantage that there's clean skipping. I guess they're concerned in lots of settings where there's public and private providers that the private providers are clean skimming the lower cost consumers. And so what does that mean in this setting? It means that Medicare Advantage plans, like to sign up, you have to walk to the 3rd floor of a walk-up. Only the healthy people can do it. It would then be consistent with upward sloping marginal costs. The first people who enroll are healthy, and as you expand market share to the full market, you get higher and higher marginal cost people. So that's the concern in this setting. If there is advantageous selection, upward sloping marginal costs, pass-through is going to be less than 1. Why? Well, as you decrease premiums, the marginal people who are coming into the market are differentially more costly. You can't drop premiums 1 for 1 and maintain 0 profits in equilibrium. So incomplete pass-through. What's the other story that could affect pass-through? Well, we know that market power could reduce pass-through below 1. It could increase it above 1. Right? Here's just the monopoly setting with linear demand, where we know that pass-through we know that monopoly reduces pass-through to 1/2 from the benchmark of unity. Okay, so what are we going to then do to move forward with this intuition? We're going to build a slightly more general model, which is going to allow us to quantitatively evaluate the importance of these different forces. So aggregate demand is Q of P. It's going to be the share of the market that has Medicare Advantage coverage. We're going to define aggregate costs for the entire industry as just the aggregation. I said aggregate costs as the sum of costs over all people who purchase Medicare Advantage. That leads to an average cost term and a marginal cost term. Marginal costs are costs for the marginal individual. We're going to think of the world as having adverse selection if marginal costs are downward sloping. The first person who enrolls is high cost, and as you increase quantity, cost is declining for that marginal person. We're going to think about the world as having advantageous selection if marginal costs and therefore average costs are upward sloping. Right? And so this would be, again, a setting with upward sloping average and marginal costs, advantageously selected market. Okay, so what's the equilibrium in this market? So this is probably familiar with, for anybody who's read NJPE with Michael. In a perfectly competitive market, premiums are characterized by zero profits. In a monopolist market, premiums are characterized by marginal costs plus a markup. We're going to introduce a conduct parameter to interpolate between these extremes, and the conduct parameter is going to nest a number of different models of imperfect competition, including Cournot. Glenn and I have a paper where we talk about the assumptions under which a conduct parameter can nest a differentiated product Bertrand. What are the assumptions you need in terms of the selection? All right. So we're defining pass-through just as the effect of a decrease in subsidies on premiums paid by consumers. Differentiating the first order conditions gives us a formula for pass-through. Rather than going through that formula step by step, let me just show you a simplification. If you assume that demand is linear and average and marginal costs are linear, then the pass-through equation separates into two terms. One is a selection term, which if we go from horizontal marginal costs, this is 1, and moves towards 0 as the market becomes more advantageously selected. As decreasing premiums is drawing in sicker and sicker patients. And the second term in this linear setting is an imperfect competition factor, which goes from 1 under perfect competition to a half under monopoly. But under different, obviously, demand specifications, this relationship could be different. The next thing we want to do then is take this model to the data. And so in particular, what we're going to do is estimate this object right here, which, as if you remember, is the first object in that pass-through equation. And it's going to be moving from 1 towards 0 as the market becomes more advantageously selected. It's two interpretations. One is the reduction in pass-through due to selection of perfect competitive model. 2, it's the proportional reduction in that linear world, if you think there's imperfect competition. Couple complications with taking this to the data. So the first complication is we don't care about the slope of average or marginal costs by themselves. We care about the slope of average costs net of any risk adjustment that is done by the government. Right? That's what matters for firms. And so we have to replace our object in the denominator with average costs net of the risk adjustment payments. That shouldn't be too conceptually complicated. We also have to scale the numerator because $1 in subsidies to firms, I think in our data only ends up being 98 cents in payments after risk adjustment. The other complication, this is a little bit more challenging, is we have administrative data on costs in traditional Medicare. Costs in Medicare Advantage are proprietary. So what has the previous literature done? There's a lot of papers on selection into and out of MA. So the previous literature has looked at switchers. Take everybody who has Medicare Advantage today, segment that, or take everybody who has traditional Medicare today, segment that group of people into people who leave next year and people who stay next year, and ask, do the people who leave have lower costs this year before they leave than the people who stay? If the people who leave have lower costs, then that's evidence consistent with advantageous selection. The healthy guys switch out. Right? So the evidence on whether there is advantageous selection is mixed. Duggan and Brown think there is. Joe Newhouse and co-authors think there isn't. No, I think these estimates are informative, but they're not perfect, right? The magnitudes are not economically interpretable, and they don't measure selection with respect to premiums, which is what matters if you're thinking about what determines premiums. So what are we going to do? We're going to make a couple assumptions which allow us to use the same approach, but recover something with more economic content. So first, we're just going to assume that the cost curves are linear, so selection is parameterized by a single slope parameter. It's what most of the literature does. The second thing we're going to do, we don't actually have to do this, but it ends up being sort of clean in terms of describing what we're doing. We're going to assume that the slope is less steep for MA plans. There's lots of evidence that HMO-style plans are good at managing costs for high-cost people, so that upward slope is going to be less steep. That's what we found in my work with John Levin and Kate Bundorf from a range of other estimates. If you make that assumption, then the slope for traditional Medicare is going to provide an upper bound for the slope in Medicare Advantage. We're going to be using selection out of one market, how average costs change if people leave one market, to learn about selection into another. And the algebra works really cleanly. I left it out just because of space constraints in the talk. Okay, so let me show you some estimates. So here's the first stage. Here's the effect of the increase in subsidies on Medicare Advantage enrollment. Right? This is independently interesting if you just want to know demand elasticities in this market. It's also important for estimating selection. If people aren't being shifted out of traditional Medicare, we're never going to be able to estimate selection. So this is just showing that our variation leads to about a 5 percentage point drop in, or 5 percentage point increase in people on Medicare Advantage on a base of 30%. So here's the main selection estimates then in the paper. This is showing the effect of a $50 10% increase in monthly payments on costs in traditional Medicare. If there was advantageous selection, then as you're taking people out of traditional Medicare, right, the remaining pool is getting sicker and sicker. And so if there was advantageous selection, you would expect costs to be increasing. This is just risk adjustment that we need to control for, so it's the net. And what comes out of these estimates is just doesn't seem to be much selection on the price margin. As you drop premiums, the remaining people in traditional Medicare are the same price as the people who were there beforehand. The people who are pulled out of the market are representative of the average pool. And so in particular, our estimates indicate that the slope going from zero, going from the cheapest person to the most expensive person, we get an increase in costs of about $150 on a base of $550. So that's a 10% variation in costs on this margin. The predictable variation in healthcare costs in a pool of individuals is more like 10 to 1, not more than that. So this is very, very little selection. So take this estimate, plug it into the pass-through formula, and this degree of selection implies pass-through can explain at most 15 cents of the decrease in premiums. So pass-through doesn't seem to be or selection doesn't seem to be the quantitatively important barrier to pass-through in this market, and therefore not the quantitatively important barrier to sort of consumer share of the surplus, at least generated on the margin in this market. Theory says that the residual is due to market power. Can we find supporting evidence? Idea, just look for heterogeneity in pass-through by pre-BIPA levels of market power. Why pre-BIPA? Well, in principle, BIPA might have affected the market structure. That would be contaminated then with pass-through. So we're going to look at the pre-BIPA number of insurance plans, pre-BIPA HHI. And here's the graphs. Right? These aren't identified. We're just looking at heterogeneity in these estimates across different places. But it's pretty compelling. In markets with just one plan, pass-through is 25 cents on the dollar. In markets with 3 or more plans, this is probably the top tercile of competitiveness, pass-through is more like 75 cents, which is pretty close to the 85 cents you would expect. So it seems like also in this data, so here's a version by HHI, It's like also in this data, it seems like market power is the more important impediment to pass through in the market, perhaps the more important distortion to the functioning. So in conclusion, we're using a sharp differential increase in MA payments to study the allocation of marginal consumer surplus. Privatized Medicare, 1/2 is passed through to consumers. This estimate by itself, right, has probably the most direct policy impact. The ACA is scheduled to cut payments to MA plans by $150 billion. Every year, the industry starts running advertisements, and the Obama administration decides to put back these cuts for a year. This tells us who's going to bear the incidence if these finally come into effect. The other thing the paper does is tries to use pass-through to learn about the functioning of the markets. We find advantageous selection has relatively less explanatory power. Market power has more explanatory power. And I think this has implications, at least for me. It shifted my prior as to what is the more important distortion in these markets and where we should be focusing policy moving forward. Thanks.
OK, thanks a lot for letting me discuss this very interesting paper. I'll admit that I'm Canadian, and about a week ago, I knew very little about Medicare. And so this was a steep learning curve for me. So the paper's basic summary, which Neale, of course, did a very good job on, was to use this variation in the Medicare capitation payments to estimate the pass-through into premiums of insurers. And then the sort of quantitative exercise in the paper is basically showing that this pass-through is difficult to reconcile with advantageous selection alone. And so instead, the paper argues that market power, which is proxied largely by pre-increase Herfindahl index, seems to play a larger role. So you know, again, Neale did a good job on this. I think a lot of people in this room know this. But the idea is essentially that when you have selection, you know, and you're stuck on the average cost curve, well, that's inefficient. And what market power lets you do, it lets you get off the average cost curve and get onto the marginal cost curve. But it takes you off the demand curve and puts you on the marginal revenue curve. And so when you have advantageous selection, you know, this can go either way. And so there can be an optimal degree of market power in markets with advantageous selection. And so I think that's sort of in the background of this paper and in Neale's other paper with Glenn. And so what the paper does is again sort of this is the formula for the first order condition for the price. And so they're going to try to recover the implied. They're going to try to calculate the implied pass-through, implied by this formula. And they're going to use traditional Medicare to estimate selection, which is something I'll have something to say about. And then they're going to use heterogeneity by plan Herfindahls to estimate market power. But and so I think one thing that's happening in the background, and maybe the paper could bring this out more, is that it should highlight that it's possible that this pass-through is optimal if the advantageous selection was enough. Like, what would be the amount of market power you would need to sort of, in light of the small advantageous selection things for this market to be efficient? And I was sort of wondering if the authors could calculate this. And in the process of thinking about how the authors would calculate this, I realized that the measure of market power implied by this pass-through formula is difficult to plug back into measures of the actual amount of competition in the market. And so this brings me to my sort of thoughts on the assumptions that you need for this to be the right formula for pass-through here. And so I think in particular, I think it rules out monopolistic competition where you can be both like zero profits and still having some surplus. So basically, one of the things that you require in these models is that there's no other source of costs beyond the selection of the individuals in the market. So there's no administrative cost. There's nothing else that can generate sort of increasing cost curve other than the selection. And so, when you have increasing marginal costs for other reasons, then it's, the pass-through rate here is not going to be completely driven by the selection parameters. It's going to be also a component of these administrative costs, which just kind of my cursory reading sort of suggests that these are very large. And I don't know if these are higher or lower than traditional Medicare. So I just don't have a sense. Or are these fixed or are they increasing? I also don't have a sense. And it seems like this is pretty important for interpreting the pass-through rate as either market power or selection requires that you have basically flat costs on everything else. And so the other sort of part about this that I found sort of like a disconnect a little bit between the model and the empirics was that the model only allows for symmetric competition, in the sense that like even between the Cournot and the Bertrand and the differentiated product Bertrand, they basically have this thing that like all the insurers wind up operating on exactly the same component of the, you're getting the same distribution of costs from the space of customers. And so I was wondering how realistic this was, given if plans can partition the space, or if insurers can partition the space and be offering different plans to different parts of the cost distribution. And there might be multiple dimensions of private information. And so I think there's like a straightforward extension of the Cournot model that actually I think makes this, like you could actually calculate this thing. And so if you just sort of took that you had this additional sort of shifter of, so if instead of firms being all homogeneous, you had them be heterogeneous with just a simple shifter to their costs, then you wind up with like something that looks, I did this morning, I think this is right, but and so you get basically where your measure of competition winds up directly being the Herfindahl index instead of this theta parameter, which doesn't sort of map back into what they into what they actually wind up using. And so you get an explicit formula for the pass-through in terms of the Herfindahl index, which you could then plug in and sort of see if that actually does explain the pass-through that you get. In sort of, what you currently do is like interact it with different terciles of the Herfindahl index, but this might be a way to like quantitatively make it part of your model. And it's important that it also changes the formula for the pass-through. That when you have this heterogeneity, you get this covariance between the quantities and the costs that might be important for the interpretation. So if the firms actually do have different quantities and the Herfindahl index is not just 1 over n, this might matter. So the other issue in the paper is that they don't actually see selection into the private. They don't actually see the costs borne by the private plan, and so they basically have to estimate it, as Neale described, from the costs changing in the traditional Medicare sector, and then say that, well, that's got to be a bound on the costs of the people going into the Medicare Advantage, but this is assuming that all that change in costs is the selection, and I think there could be other things that are changing those costs, like moral hazard, or where basically it's like it's not just the change in the type of people that it's going. Yeah, so you don't see any change left over in the traditional Medicare population, but the costs faced by the private plans could be higher because there's things like moral hazard, people are consuming more expensive health care. And so, I was wondering, if how much of this exercise is in fact, you're calling all of selection what could in fact be a combination of selection and moral hazard. And so there's this paper by one of your co-authors and Leighton that talks about upcoding, how when someone switches into the plans, you sort of see the same health condition being like upcoded into a higher cost symptom or diagnosis, and that this sort of raises some of these costs. And so this would be something that's not seen from the traditional Medicare population cost changes. Okay, and so as Neale pointed out, there's these are very complicated products, and most of the competition is happening on premiums and benefits that they observe. So they argue that they're doing very well on this. I'm not so sure that's true because these products are so complicated. So they look at premiums, they look at copays, and they look at benefits on the extensive margin. But there's benefits on the intensive margin that could move. In particular, I was wondering about maximum out-of-pocket costs, which seem like a big component potentially of healthcare costs in this, and whether or not there was anything on intensive margin of coverage that would be an important component of costs. And then besides the selection, besides the patients, there's this whole other domain of the doctors. And the doctors are going to possibly be changing their prices when they're selling to the insurance. And so I was sort of thinking and reading this, how much of the doctors are like the intermediaries in Atkin and Donaldson, where they're basically sitting between the insurance companies and the patients, or like the hospital network might be also, or the hospitals might be another sort of intermediary like this. And so that one of the things that we're that sort of is picking up here is we don't sort of see whether or not the amount that's captured by the insurance companies, who's bearing that, who's getting that money. And I was curious if the authors could look at sort of how does how do the hospital networks sort of change by the insurance companies in response to this? So do they contract? And it seems like from Neale's argument that these are very regularly constrained, but I'm not sure if everyone's operating above the constraint, so it's not binding. Okay, so just my last, so why was I very interested to read this paper despite knowing very little about healthcare? Was I think a lot of these sort of tools are actually applicable in the things I think about, which are labor markets, and in particular, like the kinds of things that made insurance very ripe for this kind of study was the availability of very detailed cost data that let you sort of see how costs changed when you altered prices, or in this case, or in this case, like the capitation payments. And so I was thinking that on the flip side of this, you could imagine that there's things about productivity that we can now see in the way that, and productivity is like the flip side of costs for the labor market. And so there's also going to be all of the same forces hinted at in these kinds of markets are going to operate in the labor market, and that these tools give us, again, like a very nice sort of price theory way of interpreting a lot of imperfections in the labor market that sort of personnel economics and labor economics have worried about. So like we can imagine that there's going to be market power, that there's going to be selection, that there's going to be moral hazard, and all of these features that appeared in the insurance context are going to be in the labor market context. And then the same kinds of identifying variation that show up in healthcare also show up in employer wage policies, where they have sort of strange kinks and strange rules of wage setting that do generate this kind of exogenous variation that let you sort of trace out how productivity responds to wage changes. So I think like very similar ideas to what's being done in this paper could be used to assess some of these forces in labor markets. Okay, so this is a great paper. It's clean. I didn't even talk about the identification because I'm pretty sold. It's quite clean, and it's got a theoretical interpretation of the coefficients. It would be nice if the authors sort of brought the model that they have closer to the data, that they could sort of read, plug in kind of the actual measures of competition they use into this, into their pass-through formulas, and like calibrate more of it. Again, I know it's like a costly data, but some sort of better, I think the authors could still push a little bit more on actually getting the costs of the Advantage plans changing. And I'm curious, like, one of the great things about price theory for like someone that does political economy is that you trace out the incidence of things in a way that let you understand the politics of like who's fighting over what and what are they fighting about. And I'm curious what the I mean, they hinted at it in terms of the peeling back on the subsidies every year, but sort of I wonder if one of the sort of steady state political economy things of this is that as more and more people come on to Medicare Advantage, basically going to be like, okay, now we can kind of further reduce the quality of fee-for-service Medicare and induce more people to take up. And so we're going to get this, I wonder if there's like a political push to kind of get this downward unraveling of the fee-for-service Medicare. And just this last point on doctors and hospitals as potential intermediaries. And that's it.
Neale, how should I think about the welfare effects of what you've estimated? I mean, you're after a broader set of issues with, you know, private provision, but if I just focus on the narrower question of, you know, what are the welfare consequences of like changing these capitations, I was having trouble thinking that through. I mean, if the policy objective is to get more people on Medicare Advantage and there's an allocative concern with doing that, there are probably a lot of tools for accomplishing that since the government is the only competitor to Medicare Advantage. If the issue is more distributive, this is a little bit of a roundabout way to redistribute to people in South Dakota or North Dakota, whichever Dakota it was. So how are you thinking about that? Like, what do you want to take from these pass-through numbers about the welfare consequences of these changes?
So one thing I can directly, I think, take from them is what is the incidence of this sort of these marginal expansions in payments. One thing I would like to do is vary the payments from 0 to infinity so I can trace out the incidence of the whole market. I can't do that.
But it's not just incidence, because it's also, I guess, this from a social welfare standpoint, there's also the question of which is the more efficient use of resources. Is it more efficient under Medicare Advantage or more efficient under traditional Medicare? Without knowing that, there's a whole other set of incidences that are just not being measured, right? So that's the piece I'm worried about. It would be one thing if it was just, you know, we have apples and bananas and we change the prices. We put a subsidy on bananas. Now we're looking at the effect of that. But here we don't know how these prices are related to the cost of service. What kinds of moral hazard are going on in the background? So that's the part I'm worried about.
So there's, I mean, maybe it's separating the efficiency question of sort of what does the social planner want to do from the, you know, I've seen the political discussion is largely centered on who gets the rents from this policy, and so I'm not looking at the size of the pie. I'm more looking at who does it go to. I agree that we want to answer both questions.
But there are also maybe rents that are going to people from traditional Medicare that are being reduced by moving people to Medicare Advantage. You're not measuring those changes. Those could be arbitrarily big.
Yeah.
I guess that's another way to put my point. That without knowing a little more about the allocated consequences here, it's hard to know about the unmeasured parts of the incidence.
Thanks.
You got some plans right there.
We gonna try?
Kevin, do you want to?
No, go ahead.
Neale, you
do this part Chicago style. Raise your hand and start talking.
you used two surveys, one on the patient satisfaction, and you didn't do it, but you checked to make sure there was no difference between traditional. Is that right? And then you did another one on outcomes, and you found no difference. So that implies to you, at least under a price theory model, that
Difference with what?
there's no difference in the quality.
Back to Jesse's question, no difference to fee to service or difference to what it used to be in Medicare Advantage?
Difference to what it used to be in traditional Medicare versus Medicare Advantage.
We looked at two things. We looked at when people get shifted onto Medicare, or when there's these change in payments. Do the people on Medicare Advantage report changes in their ease of finding a doctor, their satisfaction with like wait times on the call service? We also looked at clinical measures of people getting the right care. Nothing was going on there.
That's within Medicare Advantage.
That's within Medicare Advantage.
Between Medicare Advantage and fee for service, which is a completely
Yes.
This is related to Jesse's question. It was also related to your comments. Because you were talking about moving people from fee-for-service, which is a completely different question.
Yeah.
Well, traditional Medicare doesn't just have fee-for-service, there are also PPOs and stuff like that.
No, I agree, but he's talking about you got the existing, something within Medicare Advantage is distinct from.
So the reason why I did this analysis, suppose you thought then in response to these higher payments, like every insurer would now contract with the star hospital with the really good clinical measures and really good access to care, then you'd expect these metrics to improve. And so we analyze this sort of as a proxy for those increases in unobservable product quality, not to answer the what I think is an orthogonal question, which is what is the more efficient form of delivery of care? This is more of just who gets the marginal incidence.
So that,
Tim.
you know, the one interpretation of your results about the consumers might be these products are pretty differentiated, so they're not very price sensitive, and so we got a lot of market power, but that they're differentiated in a way, you know, the Medicare Advantages have like substantially better health benefits on one dimension and substantially worse on another, so they're, you know, not very differentiated in a way that gets you selection into the sicker. So if that's the right story, I mean, then it seems like there's substantially worse incentives even for product type selection here than there are for pricing. Right, because that's, you know, to some degree, that's a story that would suggest that some of the, you know, market power here is, you know, within the sphere of influence by the MA guys.
Product type selection.
You know, like,
sort of
you know, well, how much do I want to have the best hospitals, or do I not want to have the best hospitals? Do I want to have a, you know, how much of a copay do I want to have on the Medicare Part D? I mean, all those kind of things to sort of balance, you know.
And so I think, you know, we've seen a huge amount of this in the ACA exchanges with narrow network plans, and I think Mark Shepard's job market paper has convinced me that part of the appeal of these narrow network plans is they screen out people who like to go to the expensive hospitals. In Medicare Advantage, institutionally, because of network adequacy laws, this doesn't seem to be as maneuverable of a product dimension, but it could be. It just, you know, the regulators have been more stringent here and are less stringent in the marketplace.
You know, do they really pay these prices, or people drop out toward the end of the year or stuff like that? Could that be part of what's going on?
So my reading of the legislative environment was that, you know, the floors weren't completely anticipated, or people didn't think, weren't sure whether the laws would come into effect. And that's consistent with the data, which shows sort of premiums are pretty flat in the treated counties in the prior period. Our approach, I think, allows us to look in the data whether there is an anticipatory response. It doesn't seem to be. Remind me of your second question? Sorry.
Do people really pay the prices that you mentioned?
Yeah, I think the answer is yes. Though I should dig more into the institutions. We have monthly enrollment data, which we have looked at. So I think if they stop paying, presumably they'd be kicked out and they wouldn't show up in our quantity data. But I could start looking at monthly enrollment. I actually should, because this has been a concern on the exchanges. So it could be happening.
All right, well, one more.
Oh, you know, I was just saying, another thing here, because there are big switching costs, we know, in these plans, market power ex post, once you have a bunch of existing insurers who have lots of customers, could be very different from upfront in a market. I don't know if I don't know what pricing looks like in these plans, but if you could look separately, if they are charging different prices by age groups or something you could look at?
So
who are
we had a strong prior going in that all the action on quantity would be for 65-year-olds. You turn 65, you make a choice, and then you're basically stuck forever. We don't find that, which was surprising for us. We don't know of another form of heterogeneity which would be correlated with switching costs. If you know one, we want to look at that.